Today we'll be talking about the pulmonary tuberculosis part 2, and it is about the management of the pulmonary tuberculosis. Basically, management of tuberculosis is done by the pharmacological therapy, and there are the two lines of drugs. First line of agents and the second line of agents. Since the treatment of the tuberculosis goes for the long time, that is at least for 6 months or above, you should be cautious while starting the treatment and while choosing the proper treatment. And there are, for the first line agents, there are four major drugs, and they are isoniazid, rifampicin, and pyrazinamide, which are bacteriostatic, and ethambutol, which is bactericidal. These four drugs are chosen as the first line agent as they have got sterilizing activity. That is, they had got ability to kill all bacilli and thus sterilize the affected tissue, as well as they have got low rate of induction of drug resistance. As I have already told you, since you are going to give a patient a long term of anti-tubercular treatment, you should be cautious that the patient shouldn't develop any drug resistance. This chart taken from the Davidson basically summarizes all the major mode of action of the anti-tuberculosis drugs, first line anti-tuberculosis drug, with major sum of the side effect. For isoniazid, the mode of action is it acts on the cell wall synthesis, and the major adverse reaction includes hepatitis and peripheral neuropathy. For peripheral neuropathy, you can prescribe pyridoxine, and for rifampicin, the mode of action is DNA transcription, and the major side effect is hepatitis, or it is a febrile reaction or rash or a orange color urine. Though orange color urine is not a major side effect, but patient may get concerned. So you need to do the counseling for the patient who are about to take this medicine, that their urine will be orange color and it is of no need of OD for them. And for pyrazinamide, the mode of action is still unknown. However, the major major adverse reaction includes hepatitis, GI disturbance, and hyperuricemia. And for ethambutol, the mode of action is cell wall synthesis, and the major adverse reaction include retrovalvular neuritis and arthralgia. From this box, you could have already noticed that the most of the drugs has got the hepatitis as the major adverse reaction. So you should keep in back of your head that the hepatitis should be always considered in the patient who has got deranged liver function test after the start of the anti-tubercular drugs. And you should be extra cautious with the patient who has already got the deranged liver function test before starting the anti-tubercular drug. Now, moving on to the second line drugs. Second line drugs are only reserved for the patient who have developed drug resistance tuberculosis for the first line of the drugs, and they are classified into four groups or four categories. At the first, including the fluoroquinolones, second, including the second line injectable aminoglycosides like kanamycin, amikacin, and streptomycin, and the third, including the oral agents like ethionamide and prothionamide, and the fourth being the add-on agents, which is further divided into three subgroups, and it includes drugs like first-line drugs like pyrazinamide, ethambutol, and high-dose isoniazid, with some new drugs like betaquilin, and other drugs like imipenem, cilastatin, and meropenem. Now, you should know that there are some major changes that has occurred in the last few years in the tuberculosis management guidelines, and guidelines differs according to different country. And I'm talking today about the tuberculosis management according to the guideline of the Nepal. And in the guideline of Nepal, it has now been changed that only two sputum sample are required for the initial diagnosis of the tuberculosis. That is, previously it used to be 3 sputum samples. Now only 2 sputum samples are required for the diagnosis of tuberculosis. And previously, for the two, you have to give the sample on the different days. But now you can give both the two samples on the same days, at least with being 1 hour apart. And for the follow-up examination, only 1 sputum sample is required. And you should know that every new presumptive TB cases should have access to the gene export diagnosis. As I have already discussed in the part 1 of the tuberculosis lecture, that gene export is required for the diagnosis of the tuberculosis because it's a easy test and it detects the Mycobacterium tuberculosis when the viral load is very low also. So you should know that all the new presumptive TB cases should have access to the gene export facility. And like previously, the treatment has been divided into intensive phase and continuation phase. However, previously when the patient has been started with antitubercular drug, then at the end of the intensive phase, you used to ask for the sputum examination, and if the test still remained positive for the Mycobacterium tuberculosis, you used to extend the intensive phase. But now the guideline had changed, and even if at the end of the intensive phase, if you do the sputum examination and you find still there are Mycobacterium tuberculosis, again what you do is you move on to the continuation phase and you repeat the sputum examination after 1 month, and you commence the continuation phase regardless of whether the sputum is positive or not. And previously, streptomycin has been included in the category 2 regimen of the tuberculosis treatment, but now streptomycin has been no longer in use as a retreatment in cases of the retreatment. Now, moving on to the classification. Before starting the antituberculosis treatment, you should know if the patient is a new case or if the patient is the retreatment case. That means if the patient has, if the patient is said to be a new patient, if the patient has never been treated for life for tuberculosis or has taken antituberculosis drug for less than 1 month, and all the patient who has received antituberculosis drug in the past for at least 1 month or more, or has already completed all the medicine previously, they are all known as the retreatment cases or all known as a previously treated patient. And for the relapse patient, they can be either a true relapse or a new episode of TB caused by reinfection. And there are all other definitions you should know. Now, moving on to the further classification according to the type of resistance. As I've already told you, a patient may develop, since you are going to give a antituberculosis therapy for a long time, the patient may develop the resistance. And you should always, in case of retreatment cases, you should always look if the patient has got resistance or not. And for that, resistance has been classified accordingly. Like a patient is said to have the monoresistant tuberculosis if the patient has resistance to one first-line antituberculosis drug, and the patient is said to have the polyresistant tuberculosis if the patient has resistance to more than one first line of anti-TB drug, but the drug should be other than isoniazid and rifampicin. If the patient has got resistance to isoniazid and rifampicin, at least both isoniazid and rifampicin, and they are known as multi-drug resistant tuberculosis. And there are other terms like rifampicin resistant tuberculosis, isoniazid resistant tuberculosis, and the patient is said to have the extensive drug resistance if the patient has resistance to any fluoroquinolones and to atopiomycin, kanamycin, and amikacin in addition to multi-drug resistance. As I've already discussed previously in the investigation, how do you diagnose tuberculosis? You send for the sputum examination further to look for the acid-fast bacilli, and the sputum examination comes with the result with some signs like meaning 1+, 2+, or 3+, or it could be negative or scanty. You should know what the interpretation means. If it shows negative, that means that there was no acid-fast bacilli sent. If it means scanty, it shows scanty, then it means between 1 to 9 acid-fast bacilli were seen. If it shows 1+, then it means between 10 to 99 acid-fast bacilli were seen, and if it shows 2+, it means around 100 to 999 acid-fast bacilli were seen, or between 1 to 10 acid-fast bacilli were seen as per FEL, or if it gives the result as 3 positive, then it means between 1,000 or more acid-fast bacilli were seen, or more than 10 acid-fast bacilli were seen per FEL. And you should know if any one of the sample is positive for at least one bacilli also, then it is interpreted as the positive result, and the patient is said to have the bacteriologically confirmed pulmonary tuberculosis. And before moving to the treatment proper, you should know what are the doses of the first-line anti-tuberculosis drug. For isoniazid, it is 5 milligram per kg, and the maximum dose that can be given is 300 milligram. And for if I'm talking about the adult dose, and for rifampicin, it is 10 milligram per kg, and the maximum dose that we can go up to is 600 milligram. And similarly, for pyrazinamide, it is 25 milligram per kg, and the maximum dose that we can go up to is 2 gram. And for ethambutol, it is 15 milligram per kg. Now moving on to the treatment proper. As I've told you, we should if the patient is confirmed to have tuberculosis, either it is bacteriologically or it is clinically, and the patient may even get pulmonary or extrapulmonary tuberculosis, you should always look if the patient is a new case of tuberculosis or if the patient is the retreatment case. If the patient has never taken anti-tuberculosis drug or has taken tuberculosis drug for less than 1 month, then you will take that patient as a new TB case and you will start the patient on the treatment of the new tuberculosis case drugs. And the drug that will, as I've already told you, will divide the treatment into 2 phases, that is intensive phase and continuation phase. Intensive for such patient, new TB cases patient, intensive phase is of 2 months and continuation phase is of the 4 months. For the initial 2 months, you give the regimen of HRJT, that is isoniazid, rifampicin, pyrazinamide, and ethambutol. That these 4 drugs are given for the continuous 2 months, and after that you will switch on to the continuation phase, for in which you will give the isoniazid and rifampicin for the 4 additional months. And what to do if the patient has new tuberculosis, but the case is very severe, like the patient has CNS tuberculosis or musculoskeletal tuberculosis or miliary tuberculosis. In these cases, the intensive phase is of the same type, that is for 2 months you give the regimen of HRJD for drug regimen, but in continuation phase you will give the 3 drugs, that is HRE regimen, that is isoniazid, rifampicin, and ethambutol. And for the prolonged period, that is the continuation phase, can be prolonged from 7 months to 10 months. And now what to do if you find out the patient is bacteriologically or clinically confirmed case of the tuberculosis, and you found out the patient has already been treated for the tuberculosis, or the patient has taken for more than 1 month of anti-tuberculosis drug in the past, then you should always, for such patient, you should always subject the patients for further investigation. That is, you should look if the patient has got drug resistance or not, and that is done by using the gene export and line prof assay test. And in gene export, you look for the rifampicin resistance for and in line prof assay you look for the isoniazid resistance and other drug resistance. So if the patient has got, you subjected the patient to the line prof assay and gene export test, and you found out that the patient has got sensitivity to both the drugs, that is both first line drug, that is rifampicin and isoniazid, the treatment is as similar to the patient has got a new case. That is, the intensive phase will be of the 2 months of HRJT, and the continuation phase will be the of 4 months of HR. But you found out that the patient has got a rifampicin sensitive, but the patient is isoniazid resistance, then you give the patient with the treatment of treatment of 6 months with HRJT regimen with their levofloxacin for full duration. And you found out that since the availability of gene export is in almost in every district of Nepal, however, line prof Asia is not available everywhere. You did gene export and the patient has got rifampicin sensitivity, and you couldn't go for the line prof assay examination, then you should consider the patient as being the isoniazid resistance, and you should treat the patient with 6 HRJT for the full duration. That is, for 6 months, you will give the patient with a regimen of HRJT. And so you should know that all the patient, either it is a new case or retreatment cases who has got tuberculosis meningitis and tuberculosis pericarditis, they should receive steroid in addition to anti-tubercular therapy. Now you have started the patient on the antitubercular drugs. Now you need to do is the monitoring of the treatment. Now when to ask the, since the treatment goes for the long term, that is from 6 months to up to 10 months, when to ask for the patient to again visit the health center. It is usually, if everything goes all right, then it is usually done for only 3 times. That is at the first, at the end of the intensive phase, that is at the end of the 2 month, you'll ask the patient to again do for the sputum examination, and you will repeat the chest radiogram, and at the end of the 5th month and at the end of the treatment, that is the end of the 6th month. And as I've already told you, if the patient has got TB meningitis and TB pericarditis, they should be given a steroid, and the steroid of choice is dexamethasone or prednisolone, and it is given at the high dose in the beginning, and it is tapered off in 6 to 8 weeks. And the most frequently used drug is prednisolone, and the dose of the drug is 2 milligram per kg daily, which could be increased up to 4 milligram per kg daily in the case of most severely ill patient for 4 weeks, and the dose then should be gradually tapered. That is by 0.5 mg per kg every week over 4 weeks until finished, and that is the total duration of 2 months, that is 8 weeks. You should know there are the various programs in the community level, so that that is taken by the Nepal government, so that the patient will continue take the antituberculosis drug. That will be they will do the full course treatment, so that there will be less resistant TB in the community. So there are basically two programs for that. That one is directly absorbed treatment, also known as DOT, and the next is community-based directly absorbed treatment. In case of DOT, the patient needs to go to the nearby health center, and they should take the medication in front of the healthcare worker. In that way, they won't miss any single day dose of the tuberculosis, so that the government will be monitoring that the patient is taking the drug as prescribed by the physician. And in case of community-based directly absorbed treatment, the treatment is given for at least 1 or 2 weeks to the patient who are far away from the availability of the healthcare center. In such cases, the patient brings the empty blister pack of 1 or 2 weeks and shows that to the nearby healthcare center. After that, they could refill the medication. However, in both way, the patient is not given all the medication at once to them, so that they will go to the home and they will take the medicine. They have to be under the observation from the healthcare workers, and this will be supervised for taking the tuberculosis treatment. And in community level, the tuberculosis drugs are, as there are more multi-drugs. In intensive phase, there are 4 drugs, and in continuation phase, there are 2 drugs. These drugs are available in the blister packs. That is the combination of all the 4 drugs in one tablet, and they are given according to the weight of the patient. Now, moving on to the special situation, what to do if there are some special situation, that is if the patient gets pregnant or if a pregnant woman is diagnosed with the tuberculosis. In such cases, you should know that all the first-line anti-TB drugs are safe for the use in pregnancy, and so the pregnant woman should be treated accordingly as a non-pregnant female with the use of the first line of anti-tuberculosis drug. And what to do if the patient is pregnant and she delivered a baby. In such cases, that is in cases of the breastfeeding mother, you should ask the mother to continue breastfeeding until she is taking the anti-tuberculosis treatment. However, you may ask the patient to wear a mask while she is breastfeeding. And for the baby, you should always look for if there is any active tuberculosis. If you have ruled out the active tuberculosis in the baby, then you should give the 3-month course of isoniazid and rifampicin to the baby as a preventive therapy, and only after that you should give the patient the BCG vaccination. And for if the patient has got tuberculosis or HIV, then also there's the same TB regimen drug. We'll discuss a little about the patient who has got HIV and tuberculosis later in the lecture. And in the patient who has got liver or renal failure, you should be cautious, and you may need to do the dose adjustment, or even you may need to pull out the drug if the patient has got severe liver injury. As I've already told you, most of the drug causes the hepatitis. So how to know if the patient has got hepatitis? That is due to use of the anti-tuberculosis drug. For that, we look for the ALT, and that is if it's more than 3 times of the normal. We look for the liver function test, and if we see for the ALT, if it is more than 3 times of normal range and the patient is symptomatic, or 5 times the normal range without symptom, then the patient is said to have a ATT, anti-tubercular drug-induced hepatitis. In such cases, you should withdraw the drug immediately, and you should start on the patient either gradually or as add-on therapy. Now, moving on to the common adverse effect of the anti-tuberculosis drug and how do we manage them. If the patient presents with anorexia, nausea after the use of anti-tubercular medicine, you should ask the patient to take drugs with food or juice or before sleeping, and you should need to do the reassurance. You shouldn't stop the drugs. And if your patient presents with joint pain, you can give some NSAID like aspirin or indomethacin. And as I've told you, isoniazid causes the peripheral neuropathies, that is burning sensation in the feet. Patient will present with burning sensation in the feet and tingling sensation. For that, you could give the pyridoxine 100 milligram daily. And if the patient has got developed confusion, sleep disturbance, also you can give pyridoxine. And if the patient has got present to you and is worried about the red or orange color urine, then you should reassure the patient that it is that due to the drug rifampicin, and there is no need to get worried. However, in cases of major adverse effects, you should withdraw the drug. And as you know that the major adverse effect is mostly due to the second line drugs like the injectable drugs, like it could be deafness, dizziness, vertigo. And in first line anti-TB drugs, you should know the major side effect is hepatitis. That is, if the patient developed jaundice or the patient developed deranged liver function test, then it should be. Then you should again stop the drug, and you should start on the reintroduction. Of the drugs slowly after the hepatic enzymes normalizes. Now, moving on to the HIV-associated tuberculosis, you should know that tuberculosis is the cause of mortality in 20 to 25% of the HIV, the patient who have got HIV. And you should know that in urban setting, in some urban settings of some African countries, the prevalence of HIV among tuberculosis is almost about 70 to 80%. That is very high rate. And you should know that sputum smear are least frequently positive among tuberculosis patient with HIV infection than among with others. Thus, the diagnosis of tuberculosis with traditional technology may be difficult. So, the gold standard of the diagnosis of tuberculosis in patients who have got HIV is the culture. Or even you can look for the urine for the lipoarabinomannan antigen. And you should know one term, that is the immune reconstitution inflammatory syndrome, or IRIS, or TB immune reconstitution disease. It may come in your MCQs, and it consists of the exacerbation in systemic manifestation or respiratory signs, as well as laboratory or radiographic manifestation of tuberculosis in the patient who is started on ATT who have got HIV. That means the patient has got both HIV and tuberculosis, and he started on anti-tuberculosis drug. After 1 to 2 months, the patient may present with the exacerbation of systemic manifestation of tuberculosis, like increased lymphadenopathy or more fever, or the increased worsening of the respiratory sign, like worsening of the pulmonary infiltrates or shortness of breath, or maybe pleural effusion. And this sign is known as the IRIS. And it is associated, as I told you, associated with administration of antiretroviral therapy, and occurs in about 10% of the HIV-infected TB patient, and it usually develops 1 to 3 months after the initiation of the antiretroviral therapy. And the pathogenesis of the presumptive pathogenesis of IRIS consists of an immune response that is elicited by the antigens released as bacilli are killed during effective chemotherapy, and that is temporarily associated with the improving immune function. So if the patient has got iris, that you should ensure that the clinical syndrome doesn't represent a failure of the tuberculosis treatment or the development of the another infection. And in case of the mild paradoxical reaction, you can manage with symptom-based treatment. However, iris can result in serious neurological complication or death in the patient with central nervous system tuberculosis. And in first, as the patient has got risks of development of the iris in case of the TB meningitis, ART should not be initiated during the first 8 weeks of the tuberculosis treatment. However, you should know that if the patient has got both the tuberculosis and HIV, first you should start the patient with anti-tubercular drug, and as early as possible, you should start the patient on antiretroviral therapy. No, just only in case of the TB, if the patient has got TB meningitis, you will wait for the first 8 weeks so that there will be less chance of development of the iris. And if the iris causes severe paradoxical reaction, the treatment of choice is the use of glucocorticoids. That is, prednisolone is given for 4 weeks at a low dose, that is 1.5 milligram per kg per day for 2 weeks, and half that dose for the remaining 2 weeks. As I've told you, regardless of the if a patient has got HIV, you should always test if the patient has got tuberculosis or not. And if the patient is diagnosed with HIV and tuberculosis, regardless of the CD4 counts, you should start the patient first on the first on the anti-tuberculosis drug, and within 8 weeks, that is as early as possible, you should start the patient on antiretroviral therapy. That is usually started within the first 2 weeks of the TB treatment. And especially in the patient who has got very profound immunosuppression due to HIV, that is the CD4 plus T cell count is of less than 50, then you should start the antiretroviral therapy as early as 2 weeks. Now moving on to the latent tuberculosis. As I've told you, I've already discussed about the latent tuberculosis diagnosis in my lecture 1. If the patient has got latent tuberculosis, then all patient doesn't need to be treated. But however, if the patient has got HIV, or the patient has recent contact with tuberculosis, or the patient is the organ transplant recipient, or the patient is going to get organ transplantation, or the patient is injectable drugs users, then you should need to, or the patient is children who is below 5 years of age, or the child is breastfeeding child, then you should do the treatment of the latent tuberculosis. And there are various regimens which include isoniazid alone for 6 months or 9 months, or rifampicin alone for 3 to 4 months. However, you can even give the isoniazid plus rifampicin regimen both for at least 3 to 4 months. Now moving on to the possible treatment outcome. You diagnosed a patient either bacteriologically or clinically pulmonary or extrapulmonary tuberculosis, and you categorize the patient either it is a new case or a retreatment case, and you give the treatment from 6 months to 10 months. And now what can be the possible treatment outcome? The patient may get cured. That is, the patient has got who has been in the beginning confirmed with the tuberculosis, has got sputum negative in the last month of the treatment, or at least one previous occasion they are known to have been completely cured. And the patient who has taken completed the whole treatment, they are known as patient with treatment completed. And if the patient doesn't take patient has got take the tuberculosis drug, however, at the end of the 5th month also their sputum smear shows positive for acid-fast bacilli, then they are known as the treatment failure case. A patient may die. A patient is said to be died if the patient died during the ATT course due to any reason. It could be either tuberculosis or any other reason. And if the treatment has got interrupted for consecutive 2 or more months, then their patients are known as to the lost to follow up. This is all. Thank you.